Hello, I'm Amanda Oakley. I'm a dermatologist, and I'm going to talk today about benign and malignant skin lesions for beginners. I have some conflict of interests, particularly that I'm a consultant for MoreMap New Zealand, where these images come from. But my main position is a dermatologist at Waikato District Health Board, and I'm also an adjunct associate professor for the University of Auckland Department of Medicine. Just to remind you about the terminology in dermatology. When we're examining a patient, we need to know the distribution, so where single or multiple lesions are situated, their configuration and how they're patterned or grouped, the shape or outline of multiple lesions. We're very interested in color, and this is relative to surrounding skin. So we may talk about hyperpigmentation or hypopigmentation, as well as the Fitzpatrick skin type. That is to say, whether they're white, brown, or black skinned, and how easily that changes on exposure to the sun. An individual lesion needs to be described by its form or structure. That's to say its morphology, as well as its consistency. Is it firm, hard, soft, fluctuant, or mobile? We also look for secondary changes. That's to say, what happens if this patient has rubbed or scratched it, injured a lesion, or it's become secondarily infected. Morphology is described as macule, small flat lesion, papule, small elevated lesion, nodule, larger elevated lesion, plaque, elevated but flat-topped. How much and what type of scale, and whether it's crusted, which is dried up blood. This talk will cover both melanocytic and keratinocytic lesions and a few other common entities that are benign or malignant. Just to remind you of the structure of the epidermis. The epidermis is predominantly made up of keratinocytes. These arise from a basal cell layer of columnar cells that then change into a squamous, more flattened area of prickle cells. Above them, the granular cell layer, and then we have our barrier function of the skin, primarily in the horny cell layer. The melanocytes, which produce pigment, are found normally at the basal layer, but they send dendrites to contact multiple keratinocytes. And it is these keratinocytes that carry pigment through to the external part of the skin. A melanocyte is a cell that produces melanin. A keratinocyte produces keratin. Remember that hair, nail, and sweat are epidermal structures. Another definition to be clear on is nevus, which is a circumscribed benign malformation or proliferation, and it's named according to the predominant cell. So we have a melanocytic nevus is made of melanocytes, and a keratinocytic nevus is made of keratinocytes. Now that latter is less common, and we won't be describing that any further today. Hematomas are malformations of multiple tissue types. And that's a bit confusing because we often talk about melanocytic nevi that have hairs in them. Well, that means that they have to be epidermal in origin as well as melanocytic in origin. So there's a little bit of confusion in terminology and anatomy. When we talk about somebody having a mole or many moles, that's the lay term for melanocytic nevus or nevi, plural. And they can be very varied from one person to the next. And in some individuals, they can vary from one lesion to the next. But most people have certain patterns to their moles. A mole can be congenital, that is to say present at birth, arise during childhood, or be acquired due to some injury to the skin, which is usually exposure to ultraviolet radiation. A pathologist will describe a melanocytic nevus as being junctional when the proliferation of nevus cells arises from the junction between the epidermis and dermis. Compound if it's a junctional nevus with a dermal component, and a dermal or intradermal nevus if there is no epidermal component. And these vary from flat to bumpy or a mixture. There's a special kind of dermal nevus known as a blue nevus. The histology of a junctional nevus is shown in this photomicrograph. The arrows point to proliferations of melanocytes at the base of the epidermis. There aren't any melanocytes in the dermis. The purple spots you see are inflammatory cells or endothelial cells or fibrous cells. The result is a small brown macule. A compound nevus has the same pigmented nevus cells in the junction, but has collections of dermal cells filled melanocytes as well. This is in a more darkly skinned patient, and we can see the darkly staining melanocytes at the junction. A dermal nevus is often skin colored, and in white skinned people that can be white or pink. And in darker skinned people tends to be a darker brown than their normal skin color. In this case, there's no involvement of the epidermis, but there's a proliferation of strands of cells, they're the purple ones, in the dermis. The blue nevus has a different pattern. The cells in the dermis are spindle-shaped, but they're still melanocytes. These melanocytes in the dermis are not dendritic. A blue nevus can be a macule or a papule. Congenital melanocytic nevi are generally large and distinctive. They occur during embryological development, and there are various types and various sizes. They may bear thick terminal hair, even when not on the scalp. They look distinctive, and people call them their birthmarks. The size varies from small, classified as less than 1.5 centimeters, to medium, large, and giant. Even if you weren't afflicted with a congenital melanocytic nevus, you almost certainly develop nevi during your childhood. Nearly everyone's got a few of them. Dermal nevi are more common in children than compound or junctional nevi. They can occur anywhere because they're not really related to sun exposure, although increasingly we appreciate that sun exposure can increase the number of them. They mostly arise before the age of 10, a few during adolescence, and very few during adult life. They vary from pink to black in color. Oval shapes, symmetrical colors and structures. So nevi in children are generally unnoticed and small, but when parents notice them appear, they may express concern. They tend to be bumpy over time, starting flat and becoming increasingly bumpy, and some of them may look rather unusual. So knowing that a nevus is present in childhood is important. In adult life, it is noticed that people tend to have more melanocytic nevi on their upper back and upper arms than in other sites. But there are people who have more on their legs, in contrast. Flat lesions can become more elevated during adult life. It's important to recognize the dermoscopy features of benign melanocytic nevi. These are described in terms of their patterns and local features. So the patterns are reticular, clod pattern, and structureless, mostly. Dermal nevi are papular and may be hair-bearing. The one on the left is a firm, shiny papule with hairs coming from it. It was referred because of concerns about a nodular basal cell carcinoma. But this lesion was present since childhood, as can be seen by the thick hairs growing from it. The one on the right is a typical dermal nevus that's not on the face, a dull skin-colored bump. Notice that the skin lines are retained. Some nevi become papillomatous as you grow older. They can even be pedunculated. They have a bumpy surface, and that bumpy surface can encourage the deposition of keratin in the clefts between the bumps. So they can have a degree of scale. They can vary from skin-colored through pink, light brown, dark brown, bluish, grayish, or black. A blue nevus is very uniform in color and structure. Could be papular or macular. The color is described as steel blue, but can vary to a degree from brown with yellowish hues to black. The histology of a junctional nevus is melanocytes in the epidermis. Therefore, they're flat lesions. Compared with a compound nevus, which has a flat component, but also a papule or dermal nevus. The dermoscopy of a dermal nevus is predominantly structureless. There's no reticular, that's to say a network pattern, or the clods that we see in the childhood type of nevus. But various structures are seen. The blue nevus is always structureless and can look a bit hazy and out of focus because these cells can often be deep down in the dermis. A common pattern, especially in childhood, is the clod or globular pattern, where there are lots of mainly roundish structures. There can be additional features, and the one on the left we can see some reticular pattern, but that's not present in the one on the right. The reticular pattern is a network of pigment, which can be very uniform, although fading as you go out, or less uniform and more concerning in the lesion on the right, which has disorder of structure and some grayness, thus of concern. The structureless pattern may only be seen in the center of a lesion, or it may occupy the whole lesion, just a single color or several shades of the same brown, or in darker skin, bluish, grayish, blackish colors. Dermoscopy of a compound nevus requires two patterns. Generally, the central area is structureless and the periphery is reticular, but there are variations. Variations occur because of the part of the body as well. On the face, there's lots of adnexal structures producing hair and sweat. These adnexal structures result in hypopigmented areas. And thus, the pigment goes around these structures, forming a rather broad pseudonetwork. Palms and soles are an area where we don't see a reticular pattern. Instead, we see parallel pigment lines. There can be a lattice pattern, but not intersecting network pattern. So we've recognized melanocytic nevi, and the best way to do that is by looking at lots of them. And there's no problem finding them on any patient you wish to examine. A dermatoscope is going to be useful to become familiar with the normal patterns of these nevi. They're harmless and nothing needs to be done. However, we sometimes need to excise nevi because we can't exclude a melanoma. We also might want to excise it if the patient is annoyed by the lesion, perhaps it's getting caught on clothing. My presentation has been interrupted and I'm just recommencing where I left off. So melanocytic nevi being harmless, no treatment's required for most of them, but we might decide to excise one because we weren't 100% sure that it was a nevus, or because it was annoying to the patient. Some moles are pretty ugly, and it's understandable that people want to have them removed, but we have to remember that to remove a nevus will leave a scar. Let's move on to melanoma. You've probably heard that melanoma is classified as superficial spreading, lentigo maligna, nodular melanoma, and other types of less common melanomas. And the many flat types of melanoma have an in situ phase to start with. That means the cells are retained within the epidermis. So it's a malignant tumor or proliferation of funny melanocytes. And it can be classified according to histology as well as clinically. And nowadays, molecular classifications are becoming more in vogue. We recognize flat melanomas because they have ABCD criteria: asymmetry, border irregularity, variation in color, and different ugly ductlings, not the same as other lesions on the patient. D also stands for diameter, meaning larger lesions, greater than 6 millimeters anyway. And most of them grow very slowly. They're irregular in shape, structure, and color, and often have several colors, especially more advanced tumors. We recognize them on dermoscopy because they don't have those patterns we talked about before. That means they've got chaotic structure, and they can have clues to help us recognize melanoma as well. So here's some macroscopic pictures of two quite different looking melanomas. Very strange looking things. Each melanoma is unique and different. The left does not look like the right, and the top doesn't look like the bottom. The edges are varied. The colors are more than one color, more than two colors, and sometimes 5 or 6 colors. So the ugly duckling means that without any difficulty, a health professional can point to a lesion and say, that looks different from the other ones the patient has. It stands out. Another way of detecting melanoma is finding change over time. So this is a patient who has large and numerous moles. He's had surveillance by a mole map of his moles over a long period of time. And it was noticed in 2008 that this nevus looked quite a lot different from its appearance 4 years earlier. So the pigmented area on the corner has become larger and more irregular. Here's some more examples of superficial spreading melanoma with peculiar shapes and multiple colors. The one on the right is ulcerated. On dermoscopy, the patterns have gone. So the one on the left still has a reticular pattern, but it's not uniform across the lesion. It has a structureless pattern, but only eccentrically. It's chaotic. The one on the right is also very chaotic, although it isn't as dramatic as the one on the left. And that on the right is melanoma in situ. We're not seeing multiple colors really until you look closely and notice that there's light brown, dark brown, gray, and hypopigmented areas. The dermoscopy of a lentigo maligna, which is a type of melanoma seen on the face, is unique and often shows a pseudo network, which is rather chaotic, thick and thin brown lines, and a variable type of edge. Thick melanomas are often the most difficult to detect, even though they're fast growing and often concern the patients because they recognize there's something wrong. EFG criteria means elevated, firm, and growing. They can grow within weeks to months to become double their size. It can be any color, but red, black, and blue tend to predominate. The dermoscopy shows exactly the same features with the thin ones, a lack of pattern and clues to malignancy. Here's some examples. The one on the left is an ulcerated red melanoma, and the one on the right is a scaly bluish one. The one on the left is variable from black, blue to red and brown, and the one on the right looks more like a basal cell carcinoma, except it's not quite as shiny as we'd expect. The dermoscopy of these lesions is predominantly polymorphous vessels if they're red. So the red denotes a brisk blood supply, but this blood supply is not uniform. We've got funny blotches and weird shapes. Note also it's sticky and bits of fiber are adhering to the lesion. The one on the right shows multiple colors. It looks quite stuck on like a seborrheic keratosis, but when you examine the structures, they are melanocytic, aggregated globules, particularly, and structureless zones. So we manage melanoma by excising it with a 2 millimeter clinical margin. Patients have a second procedure with wide local excision, and the margins depend on the Breslow thickness determined with the first procedure. So what's the Breslow thickness? Well, it's measured from the granular cell layer to the top of the epidermis to the bottommost abnormal cell. Clark's level is less frequently discussed, but Clark's 1 is the melanoma in situ to Clark's 5, where the tumor extends into subcutaneous fat. Some melanomas have high risk of invasion and may undergo sentinel node biopsy to see if they have invaded into the, or at least metastasized to local lymph nodes. If you're asked to follow up a patient who's had a melanoma, examine the wound site or scar, the local nodes, and do a total body examination, as up to 25% of patients with melanoma present with another one. If they're very moly people, it may be wise for them to have digital dermoscopic surveillance, expert mole mapping. This is a private service, so not available to the whole public. Let's now consider keratinocyte lesions, which could be benign or malignant. So a keratinocyte produces keratin, which is scaly. It's epidermal, so it's on the skin surface. Benign keratinocyte lesions include viral warts, but more common in adults are terminating with a seborrheic keratoses, scaly lesions, and solar lentiginase, flatter, less scaly lesions, are harmless or not. I don't want to deal much with warts. They're pretty common in childhood and less common in adult life. Their dermoscopy shows prominent vessels within lobular structures. The benign keratosis is the name given when we are evaluating seborrheic keratoses, solar lentiginase, and lichen planus-like keratosis, which is a derivative of the other two. So a seborrheic keratosis is very, very common and occur any site where there's hair, but you don't see them on the palms or the soles or mucous membranes. They can be any color. The characteristic worth remembering is that they have a sharp border and look as if they're stuck onto the top of the skin. Dermoscopy clues are orange clods, white clods, and thick curved lines. So here's the macro pictures of a pink and a brown stuck on warty plaque. The one on the left is rather waxy. The patient on the right has hundreds of seborrheic keratoses varying from pink to black and various shades of brown and yellow. On dermoscopy, we can see white clods, which are usually round or oval. It can be small to large. We also see orange ones, which are more superficial and represent keratin in the crevices. They're irregularly distributed and may have funny shapes. The one on the right has numerous small white clods. They can be quite difficult to distinguish from melanomas at times, and this I consider my puppy dog. A solar lentigo, as the name would suggest, is due to sun exposure, but it can occur in light-skinned and dark-skinned patients and is a flat brown mark, often found on the hands or face, and sometimes legs and arms. You can have one or many. They could be small to large. They are associated with seborrheic keratoses in the sun-exposed sites, so they can develop warty papules. They have a sharp border and scalloped edge and can look rather stuck on too, but as they're flatter, it's not as obvious. There are various dermoscopic patterns. Sharp edge, retained skin lines, generally uniform in color, but not always. A scalloped edge, looks a bit moth-eaten. The yellowish color tends to point towards it being of keratinocyte origin. The lichen planus-like keratosis is an inflammatory variant of solar lentigo most often. It goes a little bit purple and then gray, and then finally disappears. On dermoscopy, the lichen planus-like keratosis is composed of uniform gray dots. So benign keratinocytic lesions are harmless, so they don't need any treatment, but the patient may wish to have treatment if it's itchy or annoying, and they can be treated by cryotherapy and sometimes by cautery or excision. But if you've got hundreds, that's really not very practical. Salicylic acid or urea cream can help them look less scaly. Now, the cancers coming from the keratinocyte vary from the precancerous actinic keratosis, the in situ cancer squamous cell carcinoma in situ, invasive squamous cell carcinoma, or basal cell carcinoma. So actinic keratoses occur very commonly in sun-exposed sites in aging skin, face, ears, scalp, hands. More prevalent in fair skin than in darker skin. They're ill-defined and tender, and the scale is very adherent to the lesion. They're often inflamed, therefore red. Here's an example of a large actinic keratosis on the bridge of the nose and a smaller one at the tip. And on the right is several actinic keratoses on the cheek of a very sun-damaged man. Keratoses on the hands. Pink, scaly, often in association with solar lentigines. So you can have brown flat marks and red scaly ones, and they can coincide. A cutaneous horn is so much thick keratin that it's horny. These can arise from squamous cell carcinoma or from actinic keratosis. We usually cut them out. Now, the dermoscopy of a facial actinic keratosis is very characteristic, with a red background on which are prominent follicles and there may be some scale. Off the face, we don't see that pseudo-network appearance, but we see scale on a red background. So how do we manage these? Well, the main thing is protecting the patient from further sun exposure, explaining that the sun is most troublesome in the middle of the day, in the middle of summer, but there is some danger all through the year during daylight hours. Recommend broad brimmed hat, long sleeves, long trousers and skirts. Sunscreen, if used, needs to be applied very frequently to provide adequate protection. To help people know how much ultraviolet is out there, you can download one of many UV apps, which give you some information about the protection needed on any particular day, at any time. So actinic keratoses can be frozen off or treated with a field treatment using fluorouracil, imiquinone, or a mixture. Sometimes surgery is needed. SCC in situ is quite common and results in single or multiple lesions in adults, mainly in sun-exposed sites, but sometimes they can occur in areas that are not exposed to the sun. So being in an armpit or a groin doesn't exclude that diagnosis. They're slowly growing irregular plaques with adherent scale. They are usually an orange-red in color and white skin, but they can be pigmented. The dermoscopy is quite characteristic. Here is SCC in situ. The dermoscopy shows crops of rounded blood vessels, and we see them in association with a growing red scaly plaque that's irregular. So sometimes we have to excise these or take a biopsy. Invasive squamous cell carcinoma is known as cutaneous squamous cell carcinoma, or SCC, is much more common in older or immune suppressed patients than younger and non-immune suppressed patients. SCC nearly always occurs on sun-exposed sites such as the scalp, ears, lips, face, hands, and legs. Generally, they will arise from a pre-existing actinic keratosis, and less often from a pre-existing squamous cell carcinoma in situ. But they can occur also in dark skin, in chronically damaged skin, particularly in patients with severe trauma, a thermal burn, or a chronic wound. These present as tender, painful, fast-growing nodules. The dermoscopy shows central keratin. Here's some example: irregular scaly plaques, often with a little bleeding or ulceration, inflammation. The one on the left is the typical cutaneous squamous cell carcinoma with a collarette of scale and a central core. The one on the right is poorly differentiated and has lost that ability to create scale. The one on the right is much more dangerous. Here's some examples showing dermoscopy: thick, scale, prominent variable vessels, tendency to two components, that is to say central scale and crust, with surrounding whitish periphery due to keratin. We cut them out. We make sure they're fully cut out, so sometimes they have a second procedure to make sure there's nothing left behind. Now, basal cell carcinoma is much more common, and there are several different types. The nodular basal cell carcinoma tends to occur on the head and neck, and we often see them in people in their 40s, but they're almost all people in their 80s and 90s will start needing excision of basal cell carcinoma if they're fair-skinned. Now, they can occur in any skin type, but they're much less common in darker skins. They can be pigmented, but are usually not pigmented in white people. Dermoscopy has some very important characteristics. Irregular pigmented structures, if there is pigment, on a pink, gray, or white background, a shiny stroma. Through the stroma can be seen linear vessels. So with this SCC in situ, we saw rounded vessels, but in a basal cell carcinoma, we see linear vessels. So a basal cell carcinoma can ulcerate early. The one on the left, there's not much tumor to see, but the one on the right, the ulcer is clearly surrounded by a lump. The one on the left hasn't ulcerated yet. The one on the right is deep in the skin, and the skin has to be stretched to discern the margins of the lesion. The dermoscopy on the left shows this grayish, whitish, pinkish stroma with very clearly observed branched irregular vessels. On the right, in a pigmented skin, there's more of a bluish color and more ulceration in this nodule, but also with clearly defined linear vessels. We cut them out. Another type of basal cell carcinoma is the superficial kind, and these are usually multiple and most often found on the trunk and superficial, proximal limbs. They're more slowly growing, and frequently patients aren't aware of them until they bleed. Here's an example on the left of a pink irregular plaque, and on the right of an ulcerated, slightly thicker plaque. The one on the left shows some pigment in it, as well as erosions. The one on the right, some regression, so the lesion is self-destructing. On dermoscopy, we may see ulceration and erosion. We may see pink with short lines, and we can often see white structure on polarized dermoscopy. In a pigmented superficial basal cell carcinoma, we'll still see erosions. The pigment tends to be peripheral, and white lines can be prominent on polarized dermoscopy. We cut them out too, but we do have some other options for small superficial basal cell carcinomas, including creams such as imiquimod and cryotherapy. They will get more. So there are two other common types of benign lesion I'd like to discuss. These are not in the epidermis. We're dealing with vascular lesions or dermatofibromas. So a dermatofibroma can be single or multiple. It is characteristically on the lower leg, but actually can occur on the trunk or arms and presents as a firm papule. It could be a pink papule or a brown papule. When you squeeze it, it tends to dimple inwards centrally. It can be pink or brown. The dermoscopy often shows that the white area centrally is surrounded by a fine peripheral network of light pigment and radial vessels. So a firm lesion with crinkly skin that dimples on lateral pressure. On dermoscopy, the central white area is often quite prominent, particularly on polarized dermoscopy. The periphery is fading brown or pink, and we usually leave them alone if we've diagnosed them confidently. Vascular lesions, because they contain blood, they are red or pink. But if the blood is deeper in the skin, they may appear purple or even blue. And in that case, they're due to proliferation of the endothelial cells, resulting in papular presentation. They're often multiple. The dermoscopy has several patterns. Another vascular common lesion is when there's dilatation rather than proliferation. These vascular lesions are squashable. So we've got a bluish angioma on the left and a reddish one on the right, purple on the left and reddish on the right, with clods, purple clods on the left and bright red clods on the right. These are typical of vascular lesions. Ectasias, where the vessels are dilated, can be red due to capillary ectasia or telangiectasia, or blue due to venule ectasia, slightly larger vessels. In this case, an apparent papule can be squashed out by pressing on it, showing that it's not a proliferative lesion. Remember that telangiectasia is quite common in quite healthy people, and the appearance should be fairly uniform, in contrast to the telangiectasia seen in a malignancy such as basal cell carcinoma. Still, if you can't be sure, get another opinion or cut it out. The TADA algorithm is useful. So you've got a skin lesion and you're not sure what it is. You've got your dermatoscope out. So if you've decided it's an angioma or a dermatofibroma or a seborrheic keratosis, this is not malignant and nothing needs to be done, apart from always suggest to the patient, come back if it changes. If you're not sure, look to see if there's architectural disorder. Is the symmetry of the structures? Yes, you may need to worry whether this lesion is a cancer or a melanoma. But if you don't see any architectural disorder, be aware that melanoma and other malignancies can appear quite symmetrical at times, and there are certain patterns and colors and structures that would make you worry, listed here. And in that case, again, biopsy or refer. So as a summing up, have a look at your spot. Is it an angioma, which is a red, blue or purple papule arising in adult life? Is it a dermatofibroma, which is a firm dermal papule with a central dimple? Or a seborrheic keratosis, which is a stuck-on, warty or waxy plaque? If not, does it have architectural disorder? Melanocytic nevi don't have architectural disorder. They arise in childhood. The color can be anything from pink to black, depending on the natural color of the patient. And they can be flat, papular, or a combination of flat and papular. We use the chaos and clues algorithm for pigmented lesions that are not angiomas, dermatofibromas, or seborrheic keratoses. We look to see whether the structure is uniform, symmetrical, and single pattern or symmetrical double pattern. If not, it's chaotic, and we look for clues. You need dermoscopy to determine whether a disordered lesion is cancer or not. But not every lesion has pigment. We have to consider what to do with skin-colored lesions. Basically, you might consider cutting them out if the skin-colored lesion is ulcerated spontaneously, has polymorphous vessels, that's to say a mixture of linear and dotted vessels, and if you see white structures, especially on polarized dermoscopy. So that's a whistle-stop tour through dermoscopy and the diagnosis of skin lesions for beginners. Many thanks for your attention. And that's the end of the presentation.